we'll move to item 4, which is Texas Institute of Excellence in Mental Health and State Hospital Link Stay Study. And who is presenting on this? Dr. Stacy, thank you. Dr. Stacy Mansoor, Senior Research Science and Associate Director. And I'm going to ruin this name here. Mahgul, is that correct? Mahgul Mansoor? Research Associate. Fourth, Annie Smith, Research Associate with the Texas Institute of Excellence in Mental Health and the University of Texas at Austin Steve Hicks School of Social Work. So, welcome.
Thank you so much. My name is Mahgul Mansoor. I'm a research associate at the Texas Institute for Excellence in Mental Health.
And I'm Annie Smith, same researcher.
All right, so we will begin our presentation. Well, thank you so much, everyone, for joining. We will be presenting findings from our length of stay study. The goal of this session is not to walk through every single data point, but to give a high-level overview of the major findings. Next slide, please. All right. So for the purpose of the study, we wanted to use both quantitative and qualitative data to identify factors that contribute to long hospital length of stay for individuals under forensic commitments. Also, by examining literature and our findings, we aim to develop actionable strategies that can address barriers related to length of stay while maintaining safety and quality of care. Next slide, please. For the quantitative side, we drew on 3 main data sources. The forensic waitlist, which includes persons served between September 2018 and October 2025. Competency restoration data for individuals discharged between June 2021 and September 2025. And an episodes of care file, which tracks persons served in the same window as the forensic data. Wherever possible, we linked the waitlist data to hospital admission data so we could follow individuals from jail to hospital and back in some cases. In total, we identified 35,731 unique persons served. Next slide, please.
So just briefly on the qualitative component of the study, we conducted site visits across 10 state hospitals between February and August of last year. Across these sites, we held 86 focus groups with a wide range of staff, as noted here: leadership, clinical teams, nursing, rehabilitation, any staffing population that we could identify, including nutritionists and data teams. In total, we estimated between 300 and 500 staff participated, and we then developed a structured code book with more than 200 codes to analyse the data and generate them, as we'll be discussing today. Next slide, please.
All right. So as mentioned by Annie, we visited hospitals in Austin, San Antonio, Rusk, Terrell, Wichita Falls, Vernon, Big Spring, El Paso, Rio Grande, and Kerrville to speak to staff, which informed the qualitative findings we are presenting today. For this presentation, we'll focus on major themes and present them in order of greatest impact on length of stay according to the coded data. Now, not every factor we mentioned will be explicitly linked to length of stay in the presentation, but this will all be detailed in the final report. Next slide, please. And before we review the drivers of length of stay, we're briefly going to look at the length of stay problem. Now, looking at the average time people on different commitments and security levels are waiting to be admitted, we see that the wait is about 173 days for 46B restoration non-maximum security unit beds, and 351 days for 46B MSU beds. For individuals on the 46C and juri not guilty by reason of insanity commitments, the wait times are shorter overall due to expedited admissions. For individuals who need restoration and maximum security, they are spending on average almost a year on the wait list before they ever get to the hospital. And consequences for both jails and hospitals are severe. Next slide, please. In 2021, when we expect to see the pandemic causing immense system pressures, we see that 75% of those needing a restoration non-MSU bed were waiting longer than 90 days to be admitted. For 46B restoration MSU, that figure was even higher at 94% waiting longer than 90 days. Next slide, please. Now, by 2025, we see some improvement, with the proportion waiting longer than 90 days dropping from 75% to 61% for 46B non-MSU commitments, and for maximum security, it drops from 94% to 70%. So while system changes and capacity efforts may be helping, there is still an unmet demand in lingering system effects of COVID, as we can see that a majority are still experiencing waits longer than 3 months. Next slide, please. Now, length of stay is also incredibly long once individuals are admitted to the hospital. And within that, there is incredible variation as a significant portion of the population faces discharge barriers. Now, rather than reporting length of stay as an aggregated average, we teased out differences by discharge outcomes to better understand outliers. For 46B individuals who have been admitted but not yet discharged, the average length of stay is about 469 days, and a third of this not yet discharged group have been in the hospital for more than a year. Specifically, those who have their commitments extended and are currently still in the hospital, they have an average length of stay of about 653 days. These individuals are occupying beds for very long periods due to various reasons that we will discuss. But ultimately, they limit the system's ability to move people off the wait list. Next slide, please. On the other hand, when hospitals are successful in discharging patients, they do so within an average of 218 days. When we break that down, we see that initial 46B commitments have an average length of stay of about 105 days and a median of 100 days, which are in the ballpark or under the mandated commitment periods depending on the offense. Extended 46B commitments still have a much longer average length of stay, about 434 days, but with a median of 262 days, meaning at least 50% are discharged within the mandated commitment period without needing an extension. Additionally, much fewer in this group, around 11%, had a length of stay of over a year. Next slide, please. Individuals on 46C commitments, however, stay much longer. For those who are not discharged, the average length of stay is about 1,228 days, about 3.5 years. And nearly 75% of the population is staying longer than a year. These statistics show that NGRI status can lock individuals into the system for extended periods. Next slide, please. And for those on a renewed commitment, even when discharge was successful, it was after an average of 989 days. And more than half of these 46C cases stayed longer than a year, with many staying multiple years. Now, these numbers include transfers to other facility as well as discharges to community, whereas the final report will make that distinction between the two. Next slide, please. Another example of when the processes work, they work mostly as intended. We see that for those that reached competency, only 10% stayed longer than a year, 3.7% longer than 2 years, and 1% longer than 4 years. However, among the individuals found incompetent, 23% stayed longer than a year, 10% longer than 2 years, and 5% longer than 4 years. There are also 2,777 individuals with no status reported, many of whom are not yet discharged. In that group, 19% stayed longer than a year, 9.5% longer than 2 years, and 4% longer than 4 years. This highlights the longer length of stay is primarily attributed to individuals who remain incompetent to stand trial or are discharged without a competency decision, or those that remain in the system. Next slide, please. Now, if we zoom in on those that are discharged within 2 years, the figure on the left shows that the data density is actually mostly concentrated under the 1-year mark for both competent and incompetent groups, meaning that these individuals discharged before 1 year. For incompetent individuals, the distribution is still shifted upward, meaning even when we limit to shorter stays, people who remain incompetent are staying longer, which could be due to a combination of factors such as continued efforts to help them reach competency or discharge barriers associated with incompetent individuals. Next slide, please. Now, looking at those that stay longer than 2 years, those that reach competency stayed an average of 1,367 days, or 3.7 years. And those discharged as incompetent on average stayed 1.5 times longer. Out of the 181 individuals are still not yet discharged, out of whom a majority have a length of stay of over 4 years. Next slide, please. But on a positive note, for discharged patients, you can see that the number and percentage of individuals found competent to stand trial has been generally increasing over the years, with excellent outcomes for those discharged while still on their initial commitment. Next slide, please. And now we'll shift into the key themes that might explain these long lengths of stay. The first major theme is justice system processes. Over and over, hospital staff has described how legal processes outside their control extend length of stay even after clinical goals have been met. The result is that patients remain in the hospital longer than clinically necessary, increasing bed pressure. Now, there are four key players in this theme: courts, jails, attorneys, and early decision pathways that shape people's trajectories.
The judicial system is currently one of the largest barriers to reducing lengths of stay.
Next slide, please.
Thank you. The decision courts are making, including repeat evaluations, rejection of hospital expert opinion, and in some cases reluctance to take individuals back into their counties, are directly impacting outcomes. This increases system pressure on hospitals who cannot move individuals out even when they're clinically ready. Next slide, please. Just briefly noting, we intended to present a few key quotes. With the time limits, we've decided to skip these, so next slide, please. Jails are another justice level issue with significant impacts on individuals. At the pre-admission stage, we're seeing limitations in medication management, missing or delayed admission information, and jails not being equipped for high acuity or geriatric individuals. During the hospital stay, individuals are being restored to competency, but without movement, we're seeing reduced morale and in some cases impacts on the broader milieu. Post-discharge, individuals are often returning to jails that are not equipped to manage their needs. We're seeing decompensation due to medication limitations and high acuity, which contributes to the revolving door issue that will come up again in another slide. Next slide, please. And next slide again, please.
All right. So for example, a total of 3,726 individuals on restoration commitments were discharged to jail or other correctional facilities. Of those, 853 returned to the waitlist or the hospital, and 200 likely returned in a decompensated state. Now, this has implications for both length of stay and resource use across the entire system. Next slide, please. Despite these justice system barriers, data shows that nearly a third of individuals were removed from the waitlist between September 2018 and 2025. For over 50% of those removed, competency restored spontaneously in jail, or they were enrolled into JBCR or outpatient services. Another 35% were removed due to charges being dropped, cases being resolved, or courts requesting removal for other reasons. Only about 4% were removed due to timing out. This shows that an impactful portion of system pressure resolution can happen outside of the state hospital. Next slide, please.
We're also seeing another justice level barrier with attorneys. Many are disengaged from both patients and hospitals. Across several hospitals, we heard concerns about attorneys coaching individuals to malinger, as hospitals are seen as preferable to jails. However, once individuals arrive at the hospital and realise they may be there longer than expected, this can lead to mistrust of staff. In some cases, this shifts previously stable environments and adds pressure to teams. We also heard repeated calls for additional evaluations at the attorney level, similar to what we are seeing in the courts. Next slide, please. And next slide, please. Looking earlier in the system, we're also hearing concerns around initial pathways. Police are not always equipped to recognise forensic mental health needs, and decisions made at that point, including charges or lack of diversion, can channel individuals into more restricted pathways. This contributes to individuals entering and in some cases cycling back through the system. Next slide, please. There are are examples of strong successes across hospitals. However, these are often driven by individual staff or specific local relationships. Where one court or county is responsive to a particular hospital, that goodwill does not necessarily transfer across regions. So while there are successes and these are important, they are not consistently replicable across the system. Next slide, please. And next slide, please. To address these challenges, hospitals are calling for increased education for courts, attorneys and law enforcement, stronger engagement across the justice system and improved coordination. In many cases, there are areas that extend beyond what hospitals can address alone, and participants are calling for broader system level support to help move this forward. Next slide, please. The second theme we've identified is system coordination, or more accurately, fragmentation across agencies. What we're seeing is not a lack of effort, but a system where multiple agencies share responsibility without always having shared coordination. What's happening is that individuals move through multiple systems, hospitals, courts, LMHAs, state agencies, etc., and each plays a role in progression. But coordination between the systems is often informal, inconsistent, or unclear. As a result, key decisions and transitions are delayed, even when the treatment goals have already been met. Next slide, please. Where this shows up at the state level, participants describe cross-agency fragmentation and communication gaps. We heard examples of policies being implemented without full system visibility or explanation, and tension between standardisation and the need for local flexibility across hospitals. Next slide, please. And next slide. At the facility level within hospitals, this shows up as internal friction, role drift, documentation burdens, and coordination challenges across teams. Staff are often navigating unclear responsibilities while also managing increasing systems pressure. Next slide, please. At the community level, coordination gaps with LMHAs were one of the most consistent findings, particularly in discharge planning and follow-through. And importantly, success in one region, as I mentioned, is not easily transferable to another. For example, Austin Hospital may work closely with Harris County, but that doesn't mean that Harris will work well with San Antonio or Rusk. What's important here is that these delays are not primarily clinical. They are coordination delays occurring where systems align, communicate, or clarify responsibility, which means individuals may remain in hospital not because they need to be there clinically, but because the system has not yet caught up around them. This directly impacts length of stay. Hospitals describe individuals remaining admitted while agencies exchange information, resolve administration steps, or determine who is responsible for the next action. So length of stay is being shaped not just by treatment, so much as it is being caught by the pace of the system alignment. Next slide, please. And I do want to emphasise this is not about a lack of effort from any one agency. In fact, we consistently saw the opposite in our research. Staff across hospitals are actively coordinating, often going beyond their roles to keep cases moving forward. What's currently holding the system together is the internal coordination, workarounds such as repurposing of staff time. Where hospitals build local relationships, they saw increases in community and judicial buy-in, individual staff stepping in to bridge gaps between systems, and while that is incredibly effective in the short term, it also means that progress is dependent on individuals rather than structured processes. Next slide, please. So what we see in this theme is a system that is working, but working through people rather than through design. As we've heard, that creates variability, delays, and ultimately extended length of stay, which leads directly into our next theme, where even when coordination is working, there are still limits on where individuals can actually go. Next slide, please. And next slide, please. The third theme I identified is community capacity limitations, and this is one of the clearest drivers of extended length of stay across all sites. We heard consistently across hospitals that individuals are reaching clinical stabilisation but cannot be discharged. This is because appropriate community options are not available. Importantly, these community systems operate outside hospital control, but they directly determine whether a discharge can occur. Next slide, please. What this looks like in practice is that there are limited available step-down placements. Facilities are unwilling to accept forensic patients, particularly those with charges or who have complex histories or belong to geriatric populations. There are gaps in specialised care for high acuity individuals, and we also heard about delays in guardianship processes, delays in activating social security and public benefits, and challenges navigating Medicaid eligibility threshold. So even when somebody is clinically ready, there's often nowhere appropriate for them to go. What this creates is a structural bottleneck, where discharge is determined by availability rather than by readiness. And in some cases, individuals remain in hospital simply because the next step in the system does not exist. This has a direct and significant impact on length of stay, and in many cases it contributes to revolving door admissions where individuals are discharged into unstable environments and then returned to hospitals, making restoration increasingly more difficult. A theme we'll continue to discuss in our final slide presentations. Next 2 slides, please. Despite this, hospitals are actively trying to work around these constraints. We saw strong examples of staff advocating for placements, building local relationships, developing creative discharge pathways, and using transition specialists to coordinate care. In many cases, hospitals are actively trying to build pathways where none formally exist. But again, much of this relies on local effort, on relationships, individual staff, and informal coordination, which means access to discharge is not always consistent. It can depend on where somebody is and who is involved in their case. So what we're seeing is that hospitals are ready to move more individuals forward, but the system beyond them is not always ready to receive them. Next 2 slides, please. Participants consistently pointed to the need for more step-down options, more specialised forensic placements, stronger community supports, more education for community to understand forensics individual needs, and more consistent follow-through across community providers. Without that, this bottleneck will remain. So in this theme, length of stay is being driven by availability and readiness of the next step in the system, not the hospitals themselves. And even when those pathways do exist, the next challenge we heard across hospitals is whether they are equipped to manage the level of complexity we're now seeing. Next slide, please.
All right. So next we'll talk about the changing population. Patient complexity is increasing, and a hospital system increasingly designed for competency restoration is now providing long-term specialized care. Hospitals are seeing more individuals with high clinical and behavioral complexity, such as TBI, neurocognitive disorders, multiple diagnoses, suspected malingering, and treatment resistance. For many of these individuals, restoration is nearly impossible, and existing step-down and community options are not a good fit, limiting the discharge pathways. At the same time, factors such as forensic histories, charges, or medical frailty increase the perceived risk and make community providers more hesitant to accept these patients. The result is a group of individuals who are clinically very challenging and for whom the system has limited, if any, appropriate downstream options. Next slide, please. Now, as shown earlier, individuals wait a long time before admission and have been waiting longer every year up until fiscal year 2023, and it starts to decrease somewhat after that. Staff reported that having individuals spend longer time in jail leads to exacerbated psychiatric symptoms, more aggressive behavior, and individuals learning to malinger or mask symptoms, which can impact length of stay outcomes and even unit milieu affecting other patients. Next slide, please. There's also an upward trend in the number of older adults in the forensic hospital population over time. Geriatric patients often have complex medical needs, cognitive impairments, and functional limitations that limit restoration probability. Yet many community settings are not equipped or willing to accept older adults with forensic history, which further complicates discharge planning and creates bottlenecks. Next 2 slides, please.
The final theme we identified is workforce capacity. While workforce is not a primary driver of extended length of stay, it acts as a cross-cutting constraint across all of the themes we've just discussed. What we've heard consistently is that workforce capacity shapes how the system responds to pressure, but that they are not the origin. The primary drivers we've discussed, legal processes, system coordination, community capacity, they are structural. Workforce is holding these pressures together. Participants described recruitment and retention challenges, understaffing in key roles, increasing workload and role expansion, and pressure on specialised staff, which affects restoration, discharge planning, coordination, and patient engagement.
I just wanted you to get aligned on the slides. Can
how
you go
many-
two more, please? Two more. Well, oh, sorry, one more slide. Thank you.
Thanks, Mahgul. What stood out most was not the shortage itself, it is what staff are doing despite these constraints. Across hospitals, we saw a strong commitment to patient care, staff stepping beyond their formal roles, local problem solving and innovation, interdisciplinary collaboration, and teams actively working to move patients forward despite system barriers. In many ways, the system is continuing to function because of workforce effort rather than a system's condition being optimal. Next slide, please. And then we step back, looking across all 5 themes. What becomes clear is that they are not separate issues. They are different expressions of the same underlying dynamic, a system sustained under pressure. Pressures from legal coordinations, pressures from coordination gaps, from limited community capacity, and pressures from increasing patient complexity. And workforce is absorbing it all. So what we're seeing is a system that is holding, but holding through effort. And while that effort is strong, it raises questions about sustainability over time, because when the system performance relies on individual effort, local workaround and continuous adaptation, it becomes difficult to maintain consistency across sites and over time. Combined, the data within these themes highlight that length of stay is a shared system challenge that spans legal, clinical and community domains. If hospitals are not provided with further support and funding, the length of stay is unlikely to change significantly. Next slide, please.
In the detailed report to follow, we'll include a literature review and evidence-based strategies, in-depth thematic analysis and evidential quotes, and an inferential analysis explaining factors associated with length of stay and readmission. Next slide, please. Well, thank you so much, and we're open for questions.
Well, thank you. Is there anyone that has questions or comments? I do want to say that the amount of data that you have gone through, I can only imagine the volumes that have gone through, especially with the design of our system and with the dispersed regions and the different circumstances per LMHA, geographical locations, all of that. And it appears from what we've seen here, and I look forward to getting the follow-up information to really get into the details of just how nuanced our whole system is, how it adapts and overcomes to make sure that these processes are followed. So anyone else have comments or questions of the presenters? All right then, thank you very much.
Thank you for your time.
Thank you.
Oh, we did?
This is Tyler Azul with ACCO. I see Dr. Brian Scott raised his hand. If you don't mind waiting just a second.
Okay, please, Dr. Scott.
Yes, thank you. Thanks for that presentation. It was very interesting. Since I'm the lead psychiatrist at the Fair County Detention Center, one of the things that struck me, or that strikes me on a regular basis, is the return of people from the state hospital that sometimes will get court-compelled medications going to the state hospital, but then they stay there and those orders expire and aren't renewed. But then when the patient comes back to the jail, they decompensate because that order is not in place. So I don't know if there's some consideration at looking at that process. I just think if more patients came back on compelled medications, it would facilitate a reduction in some of these folks that decompensate at the jail while they're waiting for the legal processes to continue.
So I would say that's definitely been captured in the final report. We did hear very similar stories, not just at jail systems, but in the communities as well. And yeah, we'll make sure that that is addressed in the report, the final.
Is there anyone else? No. Is there anyone else? All right then. Well, again, thank you very much for your presentation.
Thank you.